We'll see how lah. Now, Dr. Chan has requested a change in one of the lecture so that she can teach you all them all on a similar day. So initially, if you see on Putra Blast, or I already put this one up. So our last lecture will only ends on the 15th of December, yeah. By right, supposed to be 1st of December we end. Okay? So this one has been altered lah. So I'll see you for 1 hour just to talk about common heart condition. Then what we are going to do today is I've already put this one up. I'm sure Siti have already mentioned to everyone in class to just go and look at it. But the YouTube videos we will look through together lah. Okay. And then at the end of the day, then we will have that ECG and calculation in groups of normal and abnormal. I've already put up ECG traces, and that's for discussion. So we'll go through this one a little bit later on. Okay, so groupings, we follow your rota group. Okay, so we may just disperse maybe half an hour or something like that. If you don't want to discuss in your group, also fine and well. But if you want to discuss in your group, you just create a link, then you all go and discuss lah. All right, and look at the things together and teach each other. Then we'll come back and discuss about it. Otherwise, okay, 95 already at least. So we'll just start our lecture lah. The other day we stopped at this one, isn't it? Mean electrical axis. Okay, so do remember you got your lead 1, lead 2, and lead 3 lah. All right, in cats, mean electrical axis is actually not very useful, but mean electrical axis is still useful for dogs because the coverage is between here to here to here. So when we say axis, this is the point of the axis where it's going to be this particular area. Okay, so how do we read the ECG line? So all of them are just line, but later on, because with the box and everything, we were then able to calculate them. Okay, so you need to know what is the normal heart rate for adult dogs, the puppies, the small breed, and cats. Normally their heart rate tends to be higher. They are much more faster. So anything 180, 190 for me sometimes is fine. But if you've got somebody with like 240, 250, 220, for me it's still not okay. So that one will warrant further investigation lah. Okay, although the reference here says 240 is fine. Okay, then there is always duration as in like seconds, and amplitude millivolt. Okay, so this is what we have as in the normal measurement for P wave, the QR interval, the QRS, the R amplitude, the ST segment, not really very important for veterinary. T wave also not very important for veterinary. QT wave not important, so we are very lucky. Kalau in human, all this is very important lah. They will tell you a lot of things like myocarditis lah, myocardial infarct lah, and things like that. Okay, because in humans it's a different set of disease altogether. All right. So when you perform an ECG analysis and interpretation, the first thing you want to know is the heart rate. Okay, what is the other way of knowing the heart rate besides ECG? How do we get heart rates? I know you haven't come back, you don't have your stethoscope. How will you get to know about heart rate besides using ECG? Auscultate. So you auscultate using your stethoscope, listen to the heartbeat, the lap-dap count as one heart rate. Okay, every time whenever you listen to the heart rate, you want to listen to the rhythm also as well. Okay, so when you listen to the rhythm is you're actually checking for deviation from normal in terms of origin, automaticity, or the sequence, conductivity of the heart action. Then after that, you want to measure the complexes and interval. So what I mean by complexes and interval will be inilah. You look at the complex and you look at the interval. Okay, all right. And then you look at the waveform morphology. Okay, you look at the P wave. Cantik ke tak ni? QRS wave. QRS looks okay ke? Tall ke? Weird ke? right? So that's what uh, that's what it means by the morphology of the waveform, which we will go through at 12 to 1 o'clock. Okay, then most important thing is also to determine the mean electrical axis. So the mean electrical axis for cats, again, not very important, not very useful. In dogs, normally you want to see what is the problem, but often ECG do not diagnose the heart disease. ECG just tells you, hey, there is a component of a heart problem. All right. So with mean electrical axis, the vector always points towards hypertrophy, okay, but away from the artifact area, right? So it means that it doesn't tell you the issue in the heart, but it just tells you which part of the heart is enlarged. Itu aja, okay? So it's more reliable in narrow-chested animal breeds. So all those broad-chested animal, right, or those fatty bum obese dogs and stuff like that, they tend to be very hard to interpret lah sometimes. Okay. So again, P, Q, R, S, T. U, don't bother. T, sama ada dia naik atau turun, tak kisah. Okay. So more very important is when you look at the PQRST, you are looking at which lead normally. Which lead is more important one? When you want to read all these QRS, okay, always look at lead 2, right? Okay, Miapa say leads 2. Okay, so when we look at these ECG traces, all right, so you know lead 2, P, QRST, PQRST, PQRST, correct? PQRST. Okay, while I'm singing PQRST, you all go and find your calculator now. PQRST, PQRST, PQRST. Okay, so all these little boxes here, can you see all these 10 boxes? Okay, it's equivalent to all these 10 boxes. So when we are calculating information, we're actually getting from all these 5 boxes, 5 times 5 boxes. Okay, 5 times 5 boxes. So here it says that this one, the duration is 0.20 second. And this small little box, okay, this small little box here is 0.04 second. Okay, how did they get that? So how do you get that? It's normally based on paper speed lah. Okay, so this is all based on paper speed. All right. If it is 0.04 second, normally the paper speed has got two types. One is the 50 millimeter per second and another one is 25 millimeter per second. Okay, this one you'll need to listen very closely. Yeah? If there's still confusion, maybe I will make a video tonight and put it back on for here for you all to relook at again, because this is all about mathematics. Okay, so paper speed, how many speed? Two speed. One is 50, the other one is 25. So if it is a paper speed of 25 millimeter per second, can you press on your calculator right now? 1 over 25 is what? What is 1 over 25?
0.04.
0.04. So this 0.04, this is 0.04. Okay? 0.04 times 5 boxes. So you know that these little boxes over here is 0.2 second information. Okay? So for me, the quickest way to calculate is if I know this is if I know this is 0.22 second, then normally heart rate calculation, how do you want to calculate them? It's always per what? Per second or per minute? Per second or per minute? It's always per minute. Okay? So if you take 3 seconds information. All right, divide them by 0.2 second. You actually need 15 boxes. Okay, you need 15 boxes, huh? You need 15 boxes. For me, the rule of thumb is you times back 20. 3 times 20, see, 3 times 20 is 60 seconds. So that's equivalent to a minute. All right, so you get 15. So by right, you're just counting 15 boxes. Then you get the heart rate already. Can I? Can understand? Okay, versus here. This paper speed is 50 millimeter per second. If you take your calculator, 1 divided by 50, you're going to get 0.02 second. Right? 0.02 second means this small little box is 0.02 second. All right? So you times 5 box, then you know that this small little box over here is equivalent to 0.1 second. Okay? So 3 second information. So you 3 over 0.1, you get 30 boxes lah. All right, 3 seconds times 20, you get your 1 minute. Okay, so what does it mean by 30 boxes over here? So what you do is then you then come down over here. I've already calculated the 5 boxes for you. 30 boxes, huh? 1, 2, 3, 4, 5, 10, 15, 20, 25, 26, 27, 28, 29, 30 boxes. So in within these 30 boxes, then you will then see how many complexes that you have. So you have 1 complex, 2, 3, 4, 5, 6, 7. 7 times 20, what is your heart rate? 140. Okay, so let's say if this is the paper speed. So the difference between the paper speed is this one I will have to do. How do I get out from this one? Okay, let me make. So if this is 50 millimeter per second paper speed, normally the paper speed for that 25 millimeter per second, they'll look like this. Okay. All right. So let's say if you want 15 boxes, all right, because your paper speed was 25 millimeter per second. So all you need to count is that 15 boxes. In that 15 boxes, how many heart rate times back 20? Understand? So you're still going to get 140. Understand? Or don't understand? Or want to cry now? You have to tell me, or we'll go through during discussion later, because that's when the time you're going to calculate yourself. Okay? All right. You all say, okay, I move on. Because I cannot see your face. I don't know what's happening. All right. What is bradycardia? Sheka say, I'm confused. Later we'll come back to it lah. Low heart rate. Low heart rate. What is tachycardia? Tachy fast heart rate. So can you see this one is brady? Which one is brady? Here. Which one is tachy? Here. Okay. So this one is bradycardia, this one is tachycardia. So that's what we say by looking at the heart, looking at the ECG, you know what is the rate. So you're going to start calculating lah, is it a true bradycardia or not a true bradycardia? Okay, then we calculate what's the complexes within the 30 boxes or the 15 boxes, depending on the paper speed. Okay, so then you look at the PQRS, PQRST, they looks okay. So tachycardia, you tend to sing PQRST faster lah. PQRST, all right? Okay, so more importantly, the next part of the lecture, we're going to look at different rate different rhythms and waveform morphology. That's what it means. Just now, everything looks very regular, right? It's just slow and fast, correct? So when it comes to waveform morphology, you got a lap-dap here, lap-dap here, lap-dap. But it looks like, okay lah, the interval, maybe it's a respiratory sinus arrhythmia, something like that. Okay? But over here you say, oh, siapa P, siapa Q, siapa R, saya tak tahu. Then you say, then you'll be looking at this one. Okay, just now Dr. Crossing P, Q, R, S, T, tapi ini semua apa? P, 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 P ke? Then got Q, R, S, T ya? Then A, three complexes then nothing. Then AY appeared two, then nothing. Then suka hati dia datang tiga. Alright, so that's what you mean by rhythm. The rhythm is irregular. Okay, so waveform morphology, you want to pick out why is there any abnormality. Okay, always remember, if you have got P over here, means your SA beat to your AB note, then your Purkinje bundle of His, then your Purkinje fiber will start to fire, then you have your depolarization. Okay, so go back to your physiology for that. All right, so you're back again, your normal PQRST. Okay, when we calculate mean electrical axis, there are actually three methods. One is you use the isoelectric method, so meaning which one is perpendicular. Okay, so meaning if you look at lead 1, lead 2, lead 3, lead AVR, AVL, AVF, siapa yang paling diam sekali, tak ada naik, tak ada turun, and isoelectric? Or in these 6 traces, AVL. Okay, so if you look at the hexagonal that I've introduced the other day, all right, so we know AVR, AVL, AVF, lead 1, lead 2, lead 3. Tadi isoelectric sini kan, so perpendicular to AVL. So the mean electrical axis is lead 2. Okay, perpendicular maksudnya 90 degree. Alright, okay. Then, or either another method is you want to see the strongest deflection of QRS. Which one is the strongest? Which one is the highest QRS? Dalam 6 traces ini. Okay, lead 2. So, answer dia lead 2 loh. Alright, now there's another one more calculation which are much more accurate lah. It will give you different degree of deflection. So you need to calculate from lead 1 and lead 3. So maksudnya lead 1 and lead 3. Okay? Alright. How do we do that? So let's look at lead 1 and lead 3. Okay? You look at the R wave. R wave? No, this is not R wave. P, Q, R. Okay? You look at the R wave. Lead 1, lead 3, look at the R wave. Okay? In lead 1, how many boxes? 1, 2, 3, 4. Okay, so 4 minus the baseline over here. Sebab kadang-kadang got baseline suddenly slope up lower like that one. Okay, so you calculate 4 boxes. Okay, so in lead 1, then you mark lah. You agak-agak, you make a scale for yourself. So let's say you say your scale is right here is 10. Okay, so this is number 4. Okay, you draw a line. Then you look at lead 3. Then you calculate. Oh, this one is roughly about what? 9 boxes or maybe 10. Okay, then after that 9 minus the 0 or 10 minus 0. So you're just going to get 10. So you go to your lead 3. Okay, so just now your scale, tadi kita scale here 10 kan? Okay, you put a scale here is roughly 10. So you draw a line. Okay, so the mean electrical axis is when you draw this line from the center until where the 2 green line crosses. So this is mean electrical axis. So, okay. So you got 3 different ways of calculating. One is you can use siapa paling kecil sekali and then go perpendicular, alright? Atau siapa paling besar sekali, then you get your lead 2. But let's say if you are calculating from this method, it will give you a better calculation lah. Okay? Alright? Okay ah? Okay ke? Mira, why you confused? You have to say. Or either during practical, we try again. Okay? Where does the line ends? What do you mean by where does the line ends? How does the line meet? Okay, the scale. The green line doesn't end anywhere one line in the paper. Later you will see in the practical later that green line doesn't end anywhere. You just draw aja line tu. Okay? And then based on that lead 3, you just draw aja that line. Tapi it have to be perpendicular to the line that you have already drawn lah, identify lah. Okay, you just draw aja line tu, then that lead 3, you know it's 9 boxes in your scale. You make a scale for yourself and then you just draw that particular line. And then from the middle, all right, you measure it out and then you draw another arrow that crosses the 2 green line. Okay, then you get that is your mean electrical axis. So in this case, it's roughly about nearing to 70 plus. So 60, 70, 80, so roughly about 75 or 73 or something like that would be the mean electrical axis. Okay? Okay. Can I? So evaluation of ECG, tadi saya kata nak tengok waveform. Lepas tu saya kata nak tengok conduction disturbances. How do you read the ECG? Most importantly, first thing you look at the P wave. P wave, ada ke tak ada? Does the P wave looks normal or abnormal? Does the V wave looks uniform or variable? Okay. Sometimes it can be regular, sometimes it can be irregular. All right. After you look at all the P wave already, okay, so this is going to be the P wave over here, very small one. Then you want to see the QRS complex. Are they regular or irregular? So sometimes you have one here and then tiba-tiba one here. All right. Are they narrow or wide and bizarre? Maksudnya, they are so tinggi and they look so weirdly. They don't look like the QRS that you normally saw just now. Okay. And then after that, you want to train your eyes to see, is there a P for every QRS or is there a QRS for every P? Alright, maksudnya they will always come together. P, QRS, P, QRS. Sometimes you just have P, 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 then QRS. Or sometimes you just have QRS, 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 there's no P. Or sometimes you got P, QRS. Then suddenly P, then don't know what happened, then QRS suddenly enter. So then that's the second part of the lecture that we are going into to look at the arrhythmia and conduction disturbances. Okay, now let's move. Let's talk about P sahaja. Okay, abnormalities with this particular waveform all originate from the atria. Atria ada itu SA node, betul? Okay, so in normal P, Q, R, S, T. If it is P pulmonale, the P wave must be more than 0.4 second. Okay, so they will look very tall P. Compared to this one, they will look very tall P. Okay, if the P wave amplitude, so they look very tall and slender, and that means there is a possible right atrial enlargement. But then again, you look at the differential over here, it could be because of chronic respiratory disease, collapsing trachea, maybe there's a pneumonia, or maybe there's a tricuspid dysplasia. Okay. Then P mitrale means the duration of the waveform, is more than 0.04 second. So kalau second, you are looking at how many boxes over here lah, right? So they will be looking flat and they will take their some time, then only they, will give you a P wave. And you can see that there is a notching also as well. Okay, so P mitrale, increased duration, or there is a notch. Normally, it will indicate there's left atrial enlargement and is always associated to acquired mitral insufficiency. Okay? Yeah. So one rule of thumb is, if you see any P waveform abnormalities, they are actually not specific for each chamber. Like what I say here, oh, P pulmonale, okay, misty right-sided heart lah. P mitrale, oh, misty left-sided atrial enlargement lah. Actually, no, they are not specific for each chamber. Enlargement of each chamber may causes ECG alteration with the collateral atrium, especially in cats. Okay, so when you see this kind of changes, it doesn't mean that, okay, which chamber is affected. Okay, where does the SA node sit? Do you all still remember where's the SA node sits? In the in the mana? Mana SA node sits? Kalau pacemaker cell. Okay, in the right side of the heart, the pacemaker, SA node will be sitting over here, then the AV node. Okay? Okay, so actually the P wave don't indicate siapa punya masalah. Alright, it just tells you that the atrium has got enlargement. Okay, so P wave sangat senang sahaja, ada dua, pulmonale and mitrale. Okay, let's go on to right heart enlargement or hypertrophy. If there's the right heart enlargement or hypertrophy, they tend to have a deep S amplitude. So meaning this one lah. So this one is P, Q, R, S. See? Dalam sangat kan? P, and then you can see it's negatively deflected of the T wave. Okay, even masa dia naik, dia pun tak sampai the normal isoelectric punya plane. Okay, so it's a very deep S wave. And in human medicine, they will always ask you to see the other leads also as well lah, because consistently it will be there. So for example, in the lead 1, Q, R, S, a very deep S. Okay, AVF, nah sama juga. Q, R, S over here. Okay, tapi yang ni deep, yes, slightly low. Alright, but it will be in these other traces also as well. Okay, so when you perform the mean electrical axis, then you can do this. You can do it yourself. Look at the lead 1 and lead 3, and when you map it out, it will tell you right axis deviation. Okay, so again, this one would be pretty much typical. If it is right axis deviation, you have a whole lot of right-sided heart failure. Could be because of heartworm disease, tricuspid insufficiency, or maybe there's the degeneration of the tricuspid valve, or maybe there's going to be a congenital defect, pulmonic stenosis, tricuspid dysplasia, or a reverse shunting, or PDA. Okay, so this whole lot disease we will mention at the last day of our lecture. Okay, left-sided heart enlargement, then you'll be saying, Dr. Khor will say left-sided punya disease. So correct. So can you see that in the ECG trace, the P ada kat situ. Alright, the P is there. And then you got a very tall R amplitude. Okay, PQR, very tall R. But for you to say that it's very tall R, it must fit the criteria of more than 3 millivolt. Okay, so it's gonna have a high R wave amplitude, plus minus the duration is not very important. And sometimes you're going to have ST segment displacement. Okay, we always say PQRST naik punya kan. PQRST naik punya tapi negatively deflected. Okay, when we say segment displacement, the STs will slope down also as well. Can you see this slope down? Okay, so that's what it means by ST segment displacement. Okay, so left axis deviation of the mean electrical axis. So when you look at lead 1 and lead 3, you kira lah your R punya complex. So in lead 1, dia banyak boxes. So maybe 10, 20 or 30 boxes. Okay, then in your lead 3, you calculate. You see, got only few boxes over here. All right, so then you map it out. It's going to tell you that it's the left axis deviation. No? Okay. So if it is going to be left axis deviation kan, it doesn't tell you much. Memang kita punya jantung ialah left axis deviation. Okay? Alright. So it's often associated to mitral insufficiency, degenerative mitral valve disease, congenital defect, can be PDA, can be VSD, can be anything. Anything of the left-sided heart disease. Okay. If there is biventricular enlargement, this condition is very hard to determine accurately, but often time of diagnosis of left ventricular enlargement is more accurate lah. Okay, this is because the ventricular forces can easily counteract the increased force to the right. Remember, ECG is actually dependent on the volume and mass. Okay, put it this way. Most of the muscle mass is on the right side or the left side. Most of the muscle mass is on the left side or the right side. Left. Okay, when we look at the vector follow mana? Where has got more muscle mass, correct? When we look at the vector and ECG and the mean electrical axis, the vector will go where? Left side. Correct, Bo. Okay, so that's why even if you have got a right ventricular enlargement, it will still tell you a left axis deviation. Okay, so that's what it means by it's inaccurate. The ventricular force can easily counteract and increase force from the right. So you have to remember ECG is dependent on volume and mass lah. Okay, so biventricular enlargement ECG is not useful. Okay, but if you see some of this description, you have a large QRS complex, you have a tall S rather than a deep S, what it means, but a very tall R wave. Or maybe you have a very deep Q wave. Sometimes this might be quite characteristic. So this will just tell you, you know, there's going to be a left or right atrial enlargement. Okay. Now the differential would then be mitral and tricuspid valve insufficiency, dilated cardiomyopathy, PDA, mitral valve insufficiency. All right. Okay. ECG findings good to know, but you'll be the judge to see how useful it is in routine clinical analysis lah, right? What I mean is that ECG just tells you rate, rhythms, and pattern, but it doesn't tell you the diagnosis or what issue happens in the heart, okay? So ECG can come in many different waveform. This is what we call electrical alternance. So now we're moving forward to abnormalities in waveform. So electrical alternance, that's how they look like. Can you see this one complex? Then one huge complex, then one small complex. Everyone got P1. P, 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 Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T. Okay? But they are in the interval of a small complex and a big complex, followed by a small, big one. So that's what we call electrical alternate. Okay? And their configuration are there. They are all looking normal. And they have got a fixed complex, meaning their intervals are also okay. It always definitely will be. All right. So if you see electrical alternance, it's due to pericardial effusion, pleural effusion, alternating bundle branch block, or maybe it could be associated to supraventricular tachycardia. Okay, but often if you see this, you think about pericardial effusion and pleural effusion. Okay, small complexes, semua orang kecil-kecil aja you tengok lead 2. Okay, the R wave, kenapa dia ke bawah pula? Alright, but anyway, they look isoelectric. Okay, so they tend to look very small. But again, this is very common, yeah, especially in obesity dog or cats, deep-chested breed, or maybe they actually had pericardial effusion, pleural effusion, or there's a pulmonary edema, pneumonia, or hypothyroid. But if you see this ECG trace and you say, Dr. Khor, Dr. Khor, Dr. Khor, my cat dying. So then I'll be telling you it's a cat, right? So it's normal. Okay, so whenever you see this, if you're getting the ECG from a cat, this is normal lah. All right, so you don't have to worry about it. Let's talk about ST segment. Just now I showed you some ST depression and the slurring. Okay, so this one is depression. Elevation means you got your P, Q, R. Wow, S so high. Then you got your T and it comes down. ST segment. So this one is elevation. Okay, so if it is elevated, it doesn't tell you much low. This part of the when it's depolarization doesn't tell you so much. It just tell you all the myocardium. So it tells you whether the myocardium is having hypoxia, is there a pericardial effusion, or digitalis toxicity. Okay. Again, if it is depressed, it also could be myocardial hypoxia, hypokalemia, digitalis toxicity. See, it doesn't help you in terms of differential. Okay, what is the problem at that point of time? You only know, oh, the myocardial wall is unhappy. They are not doing all right. That's why they give you this weird rhythm. Okay? Okay, let's look at T waves. So, mana kita punya P? Ini T kan? P, Q, R, S, T. P, Q, R, S, T. This T looks taller than the P. Okay? Alright? So you have this large T wave, okay, that maybe takes up the height more than 1/4 of the R wave. Okay, so the differential would be myocardial hypoxia, ventricular enlargement, interventricular conduction disturbances, hyperkalemia, and digitalis toxicity. Any questions so far? Any question? Okay, let's go to arrhythmia. What is arrhythmia? Like, apanya nama arrhythmia? Apa maksudnya arrhythmia? Irregular heartbeat. So this irregular heartbeat is actually controlled by a few things. So when we look at arrhythmia, what it means is that there's an abnormality in the rate. So tachycardia is also arrhythmia, bradycardia is also arrhythmia, abnormality in rate. Regularity or site of the original of the cardiac impulse. Okay, and or a disturbance in conduction of the impulse that the normal sequence of activation of the atrial and ventricle is altered. Okay, one is the rate, how regular they are. Sometimes it may comes together with issue with conduction, meaning the impulse from the SA node to AV node to your bundle of His, then left bundle, right bundle, then your Purkinje fiber. So any of those, if you look at the PQRS, it looks weird to you. The rhythms are not correct. The complex don't come regularly. Okay, that it means by arrhythmia. Okay, now you're gonna cry. There's a lot of different arrhythmia. Okay, and these are some of those that, you know, in veterinary medicine, you will need to know. The rest of it is beyond us, all right? Now, it can be normal sinus rhythm, or sinus arrhythmia. If there is a disturbances in the sinus impulsa, so you have sinus bradycardia, sinus tachycardia. I know of one student who had a wandering sinus pacemaker also as well. Okay, not very common in animal, but more common in humans lah. If there is a ventricular impulse formation, there is a disturbance right at the ventricular site, then you can have ventricular premature complex, ventricular tachycardia, asystole, fibrillation. Okay, so we'll look at all these different rhythms later on. Now, this one is impulse conduction. Impulse conduction will mean dia daripada SA node tak nak cakap dengan AV node. Atau SA node, dia bercakap kepada AV node. It will send the impulse to AV node. Then AV node go to the left bundle or go to the right bundle, they got problem there. And that's why it will give you disturbance in impulse conduction. Okay, impulse conduction, very specifically, we are actually looking at the pathway of the impulse, SA node to AV node, and further on. But with ventricular impulse, the problem lies within the ventricle. With sinus impulse, the problem lies in the SA. Okay, it starts from there. Alright? So yang ni saya tak nak baca lah. Nanti we will see the traces. Normal sinus rhythm, PQRST, PQRST, PQRST. Normal lah. Okay? So the impulse starts from the SA node, go to AV node. Semua orang baik-baik. Good friends. P, good friend with the R. P, you have your R. P, you have your R. Interval pun cantik. Okay. Respiratory sinus arrhythmia is a variation in the sinus rhythm, but it's being influenced by the respiration, okay, and resulting from vagal tone inhibition. So you're going to have heart rate increases with inspiration and decrease when they expire. This is normal in dog, abnormal in cat. So respiratory sinus arrhythmia, how does it look like? You have your P, QRST. One complex over here. Stop for a while. 3 complex. Stop for a while. 3 complex. Okay? And this interval, okay not so far off also. You got that 3 complex, then 1, then 3 complex, then 1. So that's what it means by respiratory sinus arrhythmia. Okay, people? All right? If you get that in cat, then only you shout out for help. If you get it in dog, alah, it's okay lah, relax lah, nothing's going to go wrong. Okay? Okay, so that's what it means lah, inhibition at the vagus nerve. And that is why you get this irregular rhythm. Okay? Okay. Sinus bradycardia. T. PQRST. PQRST. Lambatnya jantung dia nak berdenyut. Okay, you're waiting for the traces to come. Alright? So then you have to do your heart rate calculation. And after that, you find out in each complex, you know, like in that 30 box, how many heart rate that you got. For example, if this is 30 box, so let's say our 30 box starts from here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So let's say our another 10 is over here. Let's say this is 30 boxes. So how many heart rate is there? What is the heart rate for this dog? 3 complexes. 3 times 20. So heart rate is 60. Okay. So then you look at your ECG parameter. Just now I've shown you what is the heart rate for cat, what is the heart rate for dogs, what is the heart rate for puppies and stuff like that. So if you get 60 of a heart rate, and I say this is coming from a Chihuahua, then habis lah. So this is abnormal for a Chihuahua, for example. Okay, so the heart rate is very slow. Again, you have to see what happened at that point when you were calculating the heart rate or when you were recording the ECG. Okay, it could be because of physiological changes. Was it being intubating? Was the animal having vomiting? Was there a hypothermia? Was there a after accident and there's an elevated cranial pressure? Or maybe this particular patient has a underlying hypothyroidism. Okay, pathological can be other systemic disease, perhaps associated to renal failure, or this is going to be a near death. Okay, near death coming to cardiac arrest. All right, you can have this kind of traces too. Okay. Okay. Sinus tachycardia, when you sing your PQRS complex, you instead of singing a slow song, you're gonna be singing a very fast song, rapping away maybe. All right. So you get your P, QRST, P, QRST, P, QRST. All right. They looks very, very fast. So you get your complexes, you can see them quickly. So your SA note to your AV note, then you need to do your calculation, and then you compare with what is normal, then you say, oh, very fast, the heart rate. All right, that's what you're going to get. Again, very fast heart rate can be because of stress, can be because of excitement, can be because of anxiety, can be because of the sudden pain, then the heart rate just rushed very fast, or can be because of your restraining and the animal wasn't happy to be on the table. Okay, then you can have a sudden sinus tachycardia. But if the tachycardia persists over the day or throughout the day, what I mean is like morning, you get tachycardia, 220 in this dog. Then later in the evening, this dog actually not stressful also, look at me, okay, eat fine, but when I listen to the heart rate, he's not like in fear, he's not like in pain, but the heart rate is 220. Okay, so it means something. It means it needs to be investigated. Okay, could it be having fever? Could there be an underlying hypothyroidism? Okay, shock, anemia, congestive heart failure, hypoxia. Normally, clinical presentation, these dogs are all sick looking and urgently need attention. All right, if they're in shock, this is emergency. If they're anemia, you can pick it up. The mucous membrane will be very pale. If it is congestive heart failure, you're going to see tachypnea. You can see them panting. You're going to see them having panting, dyspnea. If it is hypoxia, the animals are turning blue. Okay, so the clinical presentation are much more drastic. Okay, wandering pacemaker, just like the name says, wander, right? SA node talk to AV node. SA node go to AV node, that the impulse goes somewhere else. SA node talk to AV node, but the impulse goes somewhere else. So if you look at the ECG trace, P, Q, R, S, T. Okay, cantik, normal. P, T, Q, R, S, T. Okay, is it closer? No lah. Okay, good. P, wait, this P talk to the QRS. They're almost like, holding hands already. Okay, then this P, this one is like, where is the P? Gone. Is there a P? Yes, there is a P, but it's almost merging to the QRS. Okay, and then this P, so what it means by they are not uniform is variable information. Okay, and you can see the abnormality is only in P. QRS forever, regular one, cantik one. The duration may be slightly a bit off this one, but still acceptable. Okay, but if you look at the P, lain muka setiap hari. Alright, for every beat, they look different. Okay, so this is the wandering sinus Sinus already give you a clue that it is P wave. Okay. Another wandering pacemaker over here. You got your P, QRST. Oh, suddenly P come. QRST. P tak nak cakap pun, tiba-tiba P say something, QRST. Okay, so the P merge inside, hilang already. Okay, this P you can see is there, but it's merged. Not like this one, so isolated. Okay, so that's why when you look at the ECG trace, first thing, sing the PQRST song to find out where are they. Okay. So in wandering sinus pacemaker, the site of impulse formation has shift within the SA node, okay, to an atrial focus or the AV node. All right, could be anywhere lah around the right atrium chamber. It can be a normal physiological phenomenon in dogs. It can be, but quite rare. Okay, all you see is P wave, lain macam sahaja. Okay, only in P wave, it keeps changing. All right, and sometimes it can be associated with sinus arrhythmia. Let's say if it happens with respiratory sinus arrhythmia. Okay, so what you need to do is, okay, repeat the ECG later and see whether do you still get this wandering sinus pacemaker or not. Okay, if it goes back to normal trace, then okay, this is actually not a problem. It could be just that, that 5 minutes information that you recorded from the ECG, the dog or the cat was very stressful, and now you repeat it, there's nothing there. All right. So if it is a true wandering sinus pacemaker, normally you get clinical sign from the patient also as well. Okay. Ventricle impulse formation. Let me finish this one, then we take a 5 minutes break. Okay, I start at VPC, then we take a 5 minutes break. Ventricular premature complex, VPC. Okay, VPC gives you a normal P wave. Mana P? P hilang. P. This P sama dengan this P. Betul? Okay. You got PQRST. PQRST. Siapa ni? Alright. It gives you a very wide, tall, bizarre, weird-looking QRS with opposite direction to the T. Okay, and this P and QRS not associated pun. You got, tak tahu siapa ni, tak ada P, tak ada QRS, tapi ada satu giant kat situ. Alright, and then normally you see this kind of traces with animal which has got high heart rates. And it could be unifocal or multifocal. Unifocal means in this ECG trace, tiba-tiba ada satu giant kat situ. Atau multifocal, then you can have in like subsequent BPC, suddenly normal trace. So it could be unifocal, multifocal. Okay. What does it mean? This beat originates in the ventricle and is occurring earlier than the normal expected beat of VPC. So normally it's associated to weakness, syncope, exercise intolerance, and sudden death. Maksudnya, SA node kena cakap dengan AV node, correct? And then it follow through. Tapi, this one took over. Okay? SA node cakap together AV node, then the left ventricle, the right bundle, left bundle give you your R complex. Okay? Yang ni tak nak bercakap. Dia nak beat dulu. Alright, so that's why you got this trace. Okay, understand? So, if it is cardiac related, then you have congestive heart failure, can be because of dilated cardiomyopathy. In cases of hypoxia animal, or GDV, pancreatitis, hypokalemia, hypothyroidism can give you this VPC also as well. Digitalis toxicity, or when you have given epinephrine, you have given atropine, or maybe the animal is undergoing a hypokalemia condition, may also give you VPC. Okay, we stop for a while. I give you all 5 minutes. Boleh? Okay, 5 minutes from now, so 12:05. Go to the loo, go and stretch yourself, stand, something like that. Go and prepare your lunch if you have. Besides you can eat while I talk. Up to you. But 5 minutes, we meet back again.
Hi, doctor. Sorry, but I think you're muted.
Okay, thank you. Yes, I'm muted. Okay, I'll redo this again. We're still at the ventricle region, and just now the impulse actually comes up from here first. Okay, so with ventricular tachycardia, it's also the same. It's down at the ventricle also as well, and they are very dominant. Okay, so if you see this trace, this is just the ventricle talking. The ventricle beat, 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 beat. Cannot see atrial langsung. This one you can still see the atrium, but it's the P wave. Dia tak follow pun, there's no proper repolarization or depolarization. The P wave will just beat. Alright, he just wants to be dominant. He start talking. Walaupun P wave dah say something, tapi dia tak nak ikut. He start to beat also as well. So sometimes this trace can be very confusing, can be very hard to understand. Let's say if you look at this lead 2, you see all these R wave, R wave, R wave, bizarre, tall R wave. Then it decided to listen to P, but he doesn't want to come. And then you have that P, you got a proper QRST, then the ventricle just go on and keep on beating, and then want to sambung balik but cannot. Then this P is sitting here, and then he just decided to talk, to flutter, to just keep on firing, and then suddenly he rests for a while, and then you get your PQRST. All right, so ventricular tachycardia happens when you have more than 3 VPC. Okay, this one looks like a VPC, isn't it? Okay, it can be that. And then whenever you calculate for this, you look at the 30 boxes and then you start calculating this one, every one of them, you're going to get a ventricular rate of more than 150 beats per minute. Okay, there is no relationship between the P and QRS. Is there a P for every QRS? There's one over here. Is there a P for every QRS? There's no P pun. Okay, the QRS is just going crazy. Okay, there will be sometimes fusion, ventricular fusion, and you can capture the complexes with the P wave, meaning the P wave is actually in between all these already. It's not dominant, that's why it's not showing the P wave. Okay, it's fused already. Now, this trace, this ECG trace is actually not uncommon in cats. So what it means is you can see them in dogs more often. Okay. Ventricular flutter. Is this all P? Not really. But we're talking about ventricular flutter. So you just concentrate on the QRS, 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 QRS. Suddenly ventricle just decided to beat. Okay, then they diam-diam. QRS, QRST, QRST, QRST. Suddenly showing up. Maybe no, suddenly showing up. Okay. So it will give you a extremely rapid form of ventricular tachycardia with regular ups and down pattern. It's transient, okay, and it happens between the ventricular tachycardia or ventricular fibrillation. Okay, so you call it flutters lah. So again, the differential diagnosis may not be very helpful. If it is cardiac, it can be congestive heart failure, can be DCM. If hypoxia can happen also as well, GDV, pancreatitis, maybe. If there is a digitalis toxicity, you can have this ventricular firing also, epinephrine or atropine injection that was given. Okay. Ventricular fibrillation, just now is just flutter. Before that is just tachycardia. All right. If it is flutter, they look like this. Crocodile teeth. Okay. So rapid, disorganized depolarization of the ventricle, lack of organized impulse, there's no conduction, the ventricular conduction is not even working properly, you don't have your PQRST, semua orang mau bercakap, the ventricle just keep fire, that's why you keep on having this impulses. All right. So it's very rapid, it's irregular rhythm, and it's bizarre wave. It happens near death often, in shock, anoxia, no oxygen, this one, trauma, myocardial infarction, near-death experience, you tend to have this ECG trace being seen. You know this is emergency already. Okay? Okay. Ventricle asystole, langsung tak nak bercakap. P, QRS tak ada. P, QRS tak ada. This one lah is what you like to see in your TVB movie and your K-dramas. Okay? Beep, 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 gone. Alright, so this one is also another near death. You see this in dying patient, this is medical emergency. It indicates there's an absence of pacemaker impulse. So often you want to resuscitate. And if you see this kind of ECG traces, you don't have QRS. You've got the P there, but you know, there's a complete AV block. All right, the P wave is firing, but the AV node is actually not accepting. It's not being filtered to ask the ventricle to fire. Okay. SA block can happen during arrest. And when you see this, you get a irregular rhythm with a pause. Sometimes you get 2 times R to R interval. Okay, you get a normal P and a normal QRS. But the PR interval, they are not very constant lah. Okay, let's look at the ECG trace. P, QRST, P, QRST, P, QRST, P tak ada pun, suddenly QRS, the P is there, the T suddenly comes out. Okay, then they'll say, okay lah, P wave, you better go and work. So P come back. P, QRST, P, QRST, P, QRST. And P wave tak nak bercakap. Okay, so there's something wrong with the sinus within the atrium, and there is a block there. Okay, so this is sinoatrial. So meaning fail to impulse within the SA node. That could be due to increased vagal tone during inspiratory reflex in brachycephalic breed. If it is drug toxicity, can be due to propranolol or digitalis. Some patient that has got sick sinus syndrome, and normally they will come with clinical sign with histories of dog fainted, and there was almost near sudden death. Okay, so normally it will make owner very panicky. So SA block. Sick sinus syndrome. The keyword here, sinus, meaning the P wave. So we look at the P wave. P, QRST, P, QRST. No P, QRST. No P. Suddenly P say, okay, I bekerja, PQRST. No P. Ventricle decided to just fire. Then, no P. P, diam. Suddenly say, hey, where are you? You need to jump. Oh, suddenly maybe a small little note, maybe not, but maybe it started off with a QRS. Okay, the ventricle decided to fire. AV node decided to fire. You get your ventricular beat. P, QRST, no P, QRS. Tak tahu siapa nak bercakap ini. So it looks like ventricle. Then suddenly you got a P wave there. Okay, so all in all, you get P is not associated to your QRS, but QRS memang nak bekerja, but you get this long pause. Okay, so it's termed as sick sinus syndrome. So the problem lies again in the SA node. And when you calculate the P wave, meaning you calculate how many P's within that trace, okay, maybe this P, you're going to get a bradycardia. All right, so there's going to be a block, or maybe it's experiencing an arrest. So problem associated to this sick sinus syndrome would be it's affecting the SA node artery. Okay, remember, sinus. So sinus, atrial node artery. So this problem lies in the right atrium. And it could be influenced by digitalis toxicity. It can be a hereditary problem also as well, and has been noted to be more common in female miniature schnauzer, and is associated to weakness and syncope. So again lah, fainting, lemah, tidur sahaja, suddenly got up and then syncope already. So normally, yeah, it comes with a clinical sign lah. For you to have this kind of trace, definitely will have clinical sign. Okay. Atrial standstill. Atrial, again, at the SA node, standstill, berdiri, tegak. No lah, for me, standstill means don't want to work at all. He just stand there only. So when you look at the ECG trace, QRST, good. No P, QRST, no P. So this P decided to like, today I don't want to work. Okay, I'm not gonna conduct any impulse from the SA node. It is not a very common disease. It has been noted in facioscapular neuromuscular dystrophy. It's not a very common disease to diagnose. Okay, but again, it can be because of other conditions also as well. You can have the digitalis toxicity, hyperkalemia. They will have clinical sign of fainting, and is associated to some neuromuscular disease associated with cardiomyopathy, which is this one lah. Okay, not a common disease to diagnose. Atrial premature complex. Atrial, also SA node. Premature tells you that it's early. Okay, and give you a complex. So let's look at the ECG trace. P, QRST. Okay, kita tunggu P, QRST. T belum habis, P pun mau keluar. Right? QRST. Okay, we give a rest. P, QRST. P, QRST. P. So all these three traces is normal. So depolarization mau check habis, P decided to say, hey, work. P, QRST. Okay, you can see them merge in, they come up too early. So that's what you call as atrial premature complex. They come up very early. So the beat originate outside the SA node and disrupt the normal sinus rhythm. Okay. So any structural issue, maybe there's a lesion within the atrium, or maybe this is a secondary to chronic AV valve insufficiency. Again, our famous digitalis toxicity. Diuretic overdose also can, because often may cause hypokalemia. Okay, can give you this abnormal ECG trace too. Okay, atrial flutter. Just now we learned about ventricular flutter. So now we learn about atrial flutter. So when you see atrial flutter means atrial terlebih kerja lah ni. Okay, so you get this law. P, 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 QRS, P, 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 QRS, P, 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 QRS. Okay, so you get 3P, 3P, then QRS, 3P, then QRS, 3P, QRS. So this is what you call atrial flutter. All right. So what happened is there is actually a rapid atrial. Okay, so when you calculate your 30 boxes, then your sinus beat will be, they'll come up to be more than 250 beats per minute. Okay, so atrial repolarization is already altered. So it will result in directional sawtooth atrial complex. So in other words, in human medicine, they call this the F wave. Okay, so the problem lies here. So the P wave keeps on being dominant over here lah. Okay, again, differential, not exciting at all. Can be anything. Cardiomyopathy can be valvular disease too. Okay. Atrial fibrillation tends to be all over the place. Just now, this atrial flutter, they got a pattern. They are quite regular one. Okay, they just want to talk. Atrial fibrillation, they talk too much. Everybody wants to talk. Okay? So what you're going to see is P, 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 P. You can get a firing. This is the normal one. P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T. Okay, so atrial fibrillation, everybody firing over here. So you get all these ectopic beats, all right, within the right and left atrium. So there are numerous unorganized ectopic foci in the atrial discharging impulse at a very high rate, causing an uncoordinated activity, okay, of the atria and lost the effective muscular propulsion movement. So you tend to see absent P wave lah, because when you look at it, which one is P, right? You're not very sure. So it's just like everybody talking. So then you get all these sawtooth waves. Okay. Again, 50% cases associated with DCM can show you this kind of ECG trace. The problem lies in the atrium, so atrial enlargement. If there's a problem with the AB valve, right, and give you a backflow, then all this is stretched and then they are becoming very sick again. They can give you all these ectopic beats. And in cases of thyrotoxicosis, can give you that also as well. Okay, atrial fibrillation. Okay, so just now we talked about SA node. Okay, when we talk about all the sinus arrhythmias and abnormal waveform. Now we're going to go to the ventricle. Ventricular pre-excitation, if you look at the term itself is, it's ventricle. So you're going to look at the QRS. Pre-excited, the lebih excitement lah. Maksudnya belum suruh buat kerja lagi, SA to AB node belum fire lagi, dia sudah kata, oh, I want to fire. Okay, or I want to fire faster. Right? So you got P, QRS. Maybe this is a negative deflected T. Okay, and this is ST depression also as well. P, QRST. P very near to T already, or you get a slope. This one, don't know where is the P, but it starts to fire. Okay. So impulse activate a portion of the ventricle prematurely through an accessory pathway. Not very useful. Differential diagnosis would be congenital defect, can be because of atrial septal defect, tricuspid dysplasia, can be this acquired defect also as well, your valve issue, okay, valve getting fibrosis. So when you calculate this ventricular pre-excitation, then Dr. Khor asked you, so what's the heart rate? Oh, doctor, cannot see P wave. It's only ventricle most of the time. Okay, so what's the heart rate? So then you calculate your 30 boxes. Okay, then you calculate and say, doctor, this is more than 300, it's so fast. Okay, then you can see this PR interval, they're actually very short. Okay, only one box. All right, so if this is a paper speed of 25 milli per second, then you're going to say, oh, this is only one box, so it's 0.04. Okay, but then you still get a normal P lah, the P is there. Okay, except for this one, I cannot see, but the P is there. But surely a lot of time it looks uncertain. Okay, and then there is a slurring or notch. Notch upstroke, I think it refers to this one. Then the QRS slurring is referring to this one. Okay, coming down. In human, there is a disease called Wolff-Parkinson-White syndrome. You tend to have these traces. And again, in human, fainting spell, okay, or maybe they're having a high heart rate. They will tell you that, I think my heart rate is too fast right now. I think I'm having, or people telling you that, hey, I have a palpitation, something like that. Okay, so normally those are the clinical signs. Okay. AV block. What time are we now? Okay, another half an hour to go, almost done. AV block. Look at the normal one. Okay, normal one. First degree AV block, PQRST. Longer sikit, PQRST. Okay, not much difference than with this, isn't it? Alright. Normally, they will look at the duration here. Okay, the PR interval. You look at the PR interval. See, the PR interval is a bit longer. So this is already going to be first degree AV block. Second degree AV block, PQRST. P fire, no QRST. P fire, QRST. This one, okay, nothing. Second degree AV block. Third degree AV block will have this. Okay, now these ventricular blocks, they are very regular. They will always show you 3 missing, then another, this one fire, another 3 P wave, then another QRS. So they are actually very regular. They look cantik sahaja, no funny line, no other zigzag or no sawtooth or no whatever. The complexes always look like this in one nice straight line. Okay, now what is happening is there's a delay or interruption in the conduction at the supraventricular impulse through the AV junction. Okay, so that's why it's jammed there. P wave say, the SA node send an impulse to AV node. They jam. Okay, nothing happened. It's not accepting it. Doesn't want to work. Then the P wave comes back and send an impulse back. Okay, we will work. Okay, so they send another impulse, it's jammed. So there is a delay or interruption. So in first degree the AV block, there is a delay. Okay, PR interval delay. Second degree AV block, intermittent interruption. Okay, third degree AV block just tells you there is a complete or permanent interruption in the conduction. That's all. That's all what it means. Okay, so the degree of a block is you're gonna get these cases lah. Doctor, you tend to have more SA P wave than the R wave. Okay, and then the difference is delayed. For some QRS complex is actually missing. Okay, so you can see the duration, and this one is just longer. Examples of first degree AV block, a delay in conduction, you just get a longer PR interval. It can be in old dogs. Clinically, sometimes it can be normal. Aging animal, okay, say maybe in a Cocker Spaniel and Dachshund, it's more common to see that. They're very famous digitally toxicity. If you know that this patient is on digoxin, then you might want to watch out for this one. So sometimes it's associated to hyperkalemia or hypokalemia. Okay. So treatment is atropine. So you want to test whether this, AV block is actually not structural issue. You just give atropine, then you get all normal traces. Okay, as in like you get this normal trace lah. PQRST, everything becomes normal. Okay, so you know the problem is actually not because of the SA node. Okay, second degree AV block. Tengok ada P. QRS tak mau work. You got a P. QRS say, okay lah, I come. I work. I give you an impulse. Okay, I give you a complex. Then you got a P. Nothing. So dia biasanya akan nampak like this lah. It's like very regular thing one. Okay, intermittent interruption of the conduction, a P wave for every QRS, but a QRS complex not for every P wave. Okay, meaning it doesn't have for every P wave. Again, can be age related, can be because of hereditary issue in pugs, can be because of digitalis toxicity. third degree okay. In this kind of cases, you want to know whether it is a structural issue or not. Like we say just now, got fibrosis. If it is not an issue, you can always just give atropine and everything will fire quite well. Even if you have already given an atropine and it's still giving you this kind of complexes, then this dog will need a artificial pacemaker. Okay? Second degree AV block got type 1 and got type 2. So type 1, you will have a normal P and a QRS. So the PR intervals becomes longer and block. PR intervals become shorter. But it's okay, they have got a better prognosis. For the type 2, ventricular is lower than the atrial rate due to block P. So it's a fixed relationship between the P wave that comes up from the atria and the QRS that comes up from the ventricle. So you're going to have 2 P wave, 1 ventricle, or 3 P wave, then 1 ventricular beat. All right, so you always got a normal P wave, but you have an abnormal QRS. This one, the prognosis is more poorer because sometimes if it is a structural issue, they may need a pacemaker. Okay. Okay. Third degree AV block, which is this one. Okay. Means it's telling us that there's a complete or permanent interruption in the conduction. Can be because of congenital defect. So you get puppies coming in, you do an ECG trace, then you get, wow, like this. Then you got a shock. Okay, so young, got this kind of ECG trace, can be atrial this is a atrial defect, ventricular septal defect. So this is atrial septal defect, ASD, not AS. Infiltrative cardiomyopathy, bacterial endocarditis, myocardial infarct or hypertrophic cardiomyopathy can also give you this. Rarely seen them in HCM, but it's been reported. Severe digitalis toxicity again, hyperkalemia, and often if you have this third degree AV block, animal normally will go into syncope, seizure, or even sudden death. Okay. Right bundle branch block. Let me move this away. Right bundle branch block, AV, SA, AV. Okay, then it's block on this side. Right bundle branch block. A block in the right bundle branch resulting in late depolarization of the right ventricle. Okay, so you got your P wave, you got your P wave, Q, then your R, you're not sure. Maybe this is Q, the very deep Q, R, then this one not sure what's happening. So when you see this kind of wave, it's right atrial disease. It can be chronic valvular disease or it can be a congenital defect. So again, in terms of differential, it's not helpful. And sometimes you can see this in healthy dog, but again, you must associate with clinical sign. Okay, left bundle branch block. So left means it's going to be here lah. Okay. A block at the left posterior and the left anterior faces of the left bundle. Again, can be because of ischemia, could be any cardiomyopathies can give you this left bundle branch block. Okay, now ECG ECG does have a lot of limitation. Okay, and anyway, when you interpret an ECG, it should be in conjunction with clinical evidence. All right, what is the clinical evidence of this patient and why is it requiring to have an ECG conducted? Okay, was there a seizure? Was there a syncope? Was there a metabolic disease? Was there a kidney issue? Was there a blocked cat? So when you were auscultating the patient, then you get a rate which is not correct, either low or too high, or the rhythms were not correct, you get lap dup. Suddenly, la da, then wasn't sure, then suddenly, I couldn't hear the heart rate anymore. What's happening? All right. So it must have clinical evidence. Okay. Now, ECG tells you nothing about the mechanical status of the heart. And in fact, in terms of structural issue, it doesn't tell you much. It just tells you the conduction from the SA node to AV node, left bundle branch, right bundle branch, and the Purkinje fiber. That's all. Okay. It does not tell you the valves are pretty or not. Is there a coronary disease? Is the problem lies in the endocardium or pericardium? But it just only tells you that, oh, where is your myocardium? Okay, are they okay, doing okay or not? The atrial firing okay or not? The ventricle firing okay or not? Okay. And sometimes when you do ECG, you always have to remember, just now I say ECG is, much more better to be interpreted in a narrow-chested dog, but in fatty dog or fatty cat, or maybe if they have got a broad chested dog, right? ECG, sometimes the interpretation can be normal. So you have to look out for clinical evidence and artifacts also as well. So for example, when you perform an ECG, you should not have any artifacts. For example, this one look like sawtooth, isn't it? Looks like one of your atrial fibrillation, but I can tell you this is actually not atrial fibrillation. This is actually influence from another electrical appliances. Okay, or maybe this was done on a metal table. So it gives you all this artifact, and this artifact could not be interpreted. And sometimes whenever you're doing your ECG, then you say like, whoa, there's a slurring or there's a depression. No, I can tell you that this dog just moved the leg, and that's why the ECG pattern becomes like this. Okay, so the dog just moved one of the legs, so one of your leads will move, then it can be recorded in that manner too. Okay, so you need to interpret it properly lah. All right. Okay, ECG is having lack of sensitivity. It doesn't differentiate between chamber enlargement or hypertrophy by the changes in the QRST complex. So ECG, again, don't tell you, specifically where is big, where is thick. All right. So again, remind you back, it's all about conduction. And again, in breed variation, you tend to have limitation in interpretation. So the body, the chest conformation, is there a pericardial disease or is there a thoracic effusion? So it will give you the electrical alternance, and sometimes you might not be evaluating it properly too because of all these influences. Okay, now this one is our homework later lah. Okay, so anything so far? 12:41. Any questions so far? Try already ke? Or don't want to talk to me already? Or are you all still there? You don't understand about mean electrical axis. Okay. Later on, what we're going to do is we'll make you understand like eventually. We'll see how we're going to do this online, but we'll make you understand. Okay. So all the lecture notes are there. Later at 2 o'clock sharp, we will meet. I'll go through these few YouTubes with you. All right. Stop listening to Dr. Khor for maybe 30 minutes or so. Let's listen to other people. We will learn about PQRS just as a revision. We'll learn how to attach, and we'll learn how to use the monitor also as well, because those gadgets are actually available down at UVH. You're coming in for Rota, you will be experiencing it also as well. And then after that, we will do this ECG calculation. Okay, so this will be in groups. We will disperse. Okay, you can do it in group. I'll give you half an hour or maybe more. All right. And we'll learn how to, this is the form where you're going to use. Okay. So, and
Doctor, we cannot
yeah.
see your screen.
Okay, so because I have to share again, share content. Okay, can see now.
Yes, Doctor.
So if I change my screen to Webex ini kan, not fun. Wait. Okay, we will use this form. This form has got all your normal ECG LEDs. Okay, give you the interval, give you the amplitude. All right. Then you look at the ECG trace, which I'll show you later. So you see what is the paper speed, what is the sensitivity, and then you try to calculate the heart rate. Okay. Many of you all just now were crying. Don't know how to do this one. So we'll do, you teach each other first. Then after that, we'll come back and we'll discuss how to calculate the mean electrical axis. Okay? Okay. So then I want to go back to, you tell me if you're still seeing, okay, maybe I do this. Are you still seeing my screen?
Yeah, we see your
Okay.
picture bus.
Okay, great. So then we'll do this ECG trace. I'm very sorry, but you all will just have to understand that this is 10 boxes, this is 10 boxes, and this is 10 boxes. I don't think I can get it much more clearer than this. Okay, you look at your lead 2, you identify which is the sensitivity and which is the paper speed. This is an ECG trace of Oscar, and you use that your ECG form just now, and then you plug in the information. How much do you think it's the duration, and how much do you think is the voltage? Okay, so then after that you practice how to calculate the heart rate based on the method that I've taught just now lah, and we'll talk about it again. So then we also have got the abnormal traces. By the abnormal traces, I want like there, I put there only 6 cases. Okay, then you speed up in your group. So when you have your discussion later on the ECG form and the ECG for Oscar, then group A will attempt for case A, group 1, 7, 13, and 19 will attempt the first case, A. Then that you just follow this one. And then in the ECG trace, I've given all the traces to you all. So all you need to read is go and look at lead 2 and follow all this instruction, and then have a rough idea, look what is happening over here, and we'll discuss about it. Okay? Okay, Ka?
Okay, right there.
Okay, so all these 3 things are here. So, but we meet first before we break off. You do your little own thing, and then we meet again for discussion. Then after that, I'll show you clinical science video of all different coughing and panting. Okay, so even if I were to have practical with you, I don't think I can bring in 6, 7 dogs and show you, okay, any cough like that. So I'm going to share videos with you all lah. Okay? Okay. Okay, any questions so far before we meet at 2 o'clock? Any questions so far? Okay, if none, some of y'all may go. Some of y'all who wants to learn how to calculate the ECG, we can do one quickly. Okay, so up to y'all who wants to go. All right, go and have your lunch and we'll meet back at 2 o'clock. Okay, students? Okay. Okay, Maria, bye-bye. Students which one don't understand, speak up, please. Yes, Mira. Mean electrical axis. Okay, mean electrical, I think you all got problem with mean electrical axis, so we just go to that one. Okay, the first one is very easy. So you just use isoelectric. So you tengok mana yang very flat one. So it's this one, no? So this one is in AVL. So AVL. So perpendicular to AVL means 90 degree to AVL. So it's this one, no? Okay, lead 2. Now, another one is the strongest deflection. Okay, which one gives you the strongest R wave? Okay, so the highest R wave is actually in lead 2. So you just draw the line. So the answer is actually lead 2. Okay, the mean electrical axis is towards lead 2 and lead 2 is actually 60. Okay, how I know 60? Nah, lead 2, 60. 0, 30, 60, 90. Now, the one you are very confused is, okay, calculating from lead 1 and lead 3. Lead 1 and lead 3. Correct? Okay, what you do in lead 1 and lead 3 is just look at how tall the R is. Okay, let's look at this one. Lead 1 and lead 3. This one you just ignore, lor. Okay, most important is your lead 1 and lead 3. Now, I don't put a scale there because, sometimes the measurement may vary. I don't put a scale there. So you just have to create a scale for yourself. So for example, let's see what I can do. So let's see, this one to here, this is 5. Okay, then I put another scale. Okay, I put another one. This is 10. You so small. Okay, but you all understand, right? Then I put another one more. This lead 3 ma. I'm interested in lead 3 ma. I put this as another 5. Okay, then I put another one. Then I put another one. Scale. Say this is my 10. Okay, can see this 10? Can? Okay, so you look at lead 1, lead 3. So 1, how many boxes? How tall is it? So if you count, there's roughly about 1, 2, 3, 4 boxes. You don't have to be very detailed one. If you say 5 boxes, I'm not going to scold you also as well because it doesn't make any difference. So let's say it's 5 boxes. So I move this line over here. I draw perpendicularly 90 degree to lead 1. Okay, boleh. I draw a longer line. Okay, so in lead 3, it's about 10 boxes. Okay, I draw perpendicularly. This one just now I made a scale of 5 and this one is 10 kan. Let's say this is 10. So I draw a line perpendicular to lead 3. So I draw lah this line. Okay, then I draw this one. Center here and cross over here. So I pun lukis lah. Okay, so I'm going to draw. Okay, so it starts from here. I draw. It crosses here. So this is my main electrical axis. So my main electrical axis now has moved to perhaps maybe 67 or 68. Then you just write the answer. Between 60 to 70, I'm not going to scold you also as well. Okay? Or you want to be very specific. Oh, 67, doctor. Okay, betul Nabila. All right? Now you understand? Okay, makes sense. Okay, thank you. Now makes sense. Apa just now another person say what? Wait. I don't know where is the... By the way, doctor, what's the 0? 0 nothing one. That 0, sometimes you get this baseline. Sometimes this baseline is supposed to be a very nice baseline, right? But this baseline drop. So sometimes this particular line comes down, then only go up. So that anything lower than that, you minus, for example, this one, minus 2. So sebenarnya dia punya height adalah 2. Okay?
Doktor.
Hmm.
So the one that you said, the minus tu maksudnya every time the line goes down lower than the baseline, we just need to like
Minus lah.
minus the box.
Minus 1 box or minus 2 box. That's all.
Okay.
Okay? But actually, tak minus pun tak apa. Tapi this is the criteria of how it is being calculated. Okay, so later you practice lah and give it a go. Okay, some of you all may have problems with calculator. This is how I calculate it so that it becomes faster for me. But there are actually many ways and you don't have to follow my formula. I choose 3 seconds is because it's easier to calculate. So like speed, you got 50 millimeter per second and 25 millimeter per second. Okay, so depending on the speed, then the duration of the box is different lah. Okay, so let's say you choose, the easiest and always we will do is the paper speed of 50. Kecuali kita nampak, wah, dia punya heart rate so slow. In this ECG, I only get, one complex, 2 complex, then 3 complex. I want to calculate heart rate. Okay, so we increase the paper speed, then suddenly you get all the heart rate becomes faster. All right, okay, understand? Okay, so let's say we choose paper speed of 50 millimeter per second. 1 divided by 50 will tell you that this one small little box is 0.02 second. 5 boxes, then this one box over here, is 0.1 second information. So you have to do, you have to do a proportional calculation. So let's say if I want to calculate 3-second information, okay, so then I will need 30 boxes. And these 30 boxes only give me 3-second heart rate. All right, for me to get a 3-second heart rate and then convert it to beats per minute, 3 times 20 is 60 seconds. So how many heart rate that I get in within that 3 seconds, I need to times back with 20 to get the actual heart rate. So in this case, if it is 50 millimeter per second, theoretically, you just calculate 30 boxes. Okay, and in that 30 boxes, 1, 2, 3, 4, 5, 6, 7, 8 complexes, for example. So 8 times 20. So I'm getting a heart rate of 160. Okay, so this one you might want to sit down with your classmate later or your groupmate later and let them teach you. But if still don't understand, then we will still discuss about it. Okay? Okay, Tasnim? Okay, Farha. All right. We disperse for a while lah. I think it's already too much already. So disperse for a while. 2 o'clock, I'll see you all back. Okay? All right. Thank you, guys. Thank you, class. Have a
Doctor,
happy
I have one more question. How do you determine the left and right axis deviation of the MEA?
How do I determine a left and right? For example, let's go and find this one. Okay. Lead 1 and lead 3. This one normally will give you a right axis deviation. Lead 1 got how many box? You tell me. Okay, we give it a go. Who was the one who asked me this question? Lead 1 got how many box? Say lah.
2 blocks.
So lead 1 got about 4 boxes lah.
I cannot see actually.
Can you see my screen? I don't know if this one will work or not. Okay, lead
Yeah,
1.
it's about 4. I can see.
Then this lead, you see this one got a negative deflection. Okay, so this one you might want to minus. So this one is about 4 boxes, 5. So about 10 boxes also as well. This one don't give a negative deflection. This one is not a very good example. But when you say negative deflect, when you say, sorry, it's not a good example. When you say it's right axis, right, what's going to happen, the mean electrical axis will point towards here. So when they do the calculation, so something like they come over here, and then this one, you know, the mean electrical axis will point towards here. So what means is right axis deviation, mean electrical axis to the right. So in dogs, you see, in dogs, let's say if you did the calculation, or maybe the P wave is negatively deflected, so the line will come over here. Okay, if the P wave is negatively deflected, so this one is positive deflection, this one is negative deflection. So if you see the P wave, the R wave comes down slightly lower, okay? Then the line would then be here. Okay, then only you look at the R wave, then you see where is the intersection. So negatively deflection, the examples for calculation is not much, right? But what happens is most of the time, those heartworm disease, they will give you a negative deflection because the atrophy or the enlargement of the heart chamber is often on the right side. Okay, so then they will give you a slight negative deflection like what I've shown you just now lah. When you do your calculation, it will be almost like that. Okay, so then the R wave normally will be negatively deflected. Okay, so then you will see what is the scale looking like lor. Then you compare with this one. So negative deflection means it should be coming up over here. Okay,
Okay, thank you, doctor.
I'm not giving you a good example, sorry. But mean electrical axis, then it will be looking like this. Okay? Okay. Any more question? If not, then we rest for a while. I'll see you back later at 2 o'clock. All right. Thank you, class.
Thank you, Doctor.
See you all later.
Doctor.
Okay, bye-bye.